medications that are used within the renal genitourinary system. So we have urinary tract antiseptics. So they inhibit the growth of bacteria in the urine, and these medications can only be used for infections within the urinary tract. So they do not inhibit the growth of bacteria in blood or tissues, just those in the urinary tract. So examples are fosfomycin, methenamine, and then nitrofurantoin or macrobid. All right, so fosfomycin, it's available as granules. You want to mix it with half a cup of cold water, stir well, and drink. Medications that increase GI motility will decrease the absorption of fosfomycin, so you want to try to avoid those with concurrent use of fosfomycin. Methenamine, it's only used for chronic UTIs. It's really only going to be prescribed by urologist. It may cause crystal urea, so you want to encourage adequate fluid intake. It should not be used in patients with renal impairment. It can also generate ammonia, so it should not be used in patients with liver dysfunction. It requires very acidic urine with a pH of 5.5 or lower. And then you want increased fluid intake, but then on this specific medication, increasing fluid intake too much will reduce the antibacterial effects by diluting the medication and raising the urine pH. So it's very tricky. Just know the specifics of it as far as it requires acidic urine. You don't want too much fluid intake because it can reduce those antibacterial effects of the medication, and then it can generate ammonia, so you want to avoid use in liver patients. Nitrofurantoin or macrobid, it's very commonly used for the treatment of UTIs. You want to give with milk or meals to minimize GI upset. You might have some pulmonary side effects, including shortness of breath, chest pain, or cough. Those pulmonary side effects will resolve in 2 to 4 days after stopping the medication. You may have a harmless brown color to the urine, so educate the patient that that will be normal, and it is contraindicated in patients with renal impairment. Your fluoroquinolones examples, these are your fluoxetine medications. Examples are ciprofloxacin and levofloxacin, Cipro for short for the ciprofloxacin. For all fluoroquinolones, there is an increased risk for tendinitis and tendon rupture. So the Achilles tendon is most commonly involved. That risk gets greater when used in patients over the age of 60 or those taking steroids. So definitely know that tendinitis is a possible side effect, and your patient will need to be educated on this as well. You want to give all your oral fluoroquinolones with a full glass of water, and you want to ensure adequate urine output in order to minimize the development of crystal urea. Some side effects of fluoroquinolones, they may cause dizziness, drowsiness, GI upset, diarrhea, nausea, vomiting. The main thing to know about fluoroquinolones is that increased risk for tendinitis and tendon rupture. All right, so sulfas. Sulfurs are used primarily to treat acute UTIs. An example is Bactrim. You want to take these on an empty stomach with a full glass of water. Educate the patient that the urine may turn dark brown or red. That is normal. Side effects may be Stevens-Johnson syndrome. If Stevens-Johnson syndrome occurs, you want to stop the medication immediately. And then if you remember, sulfa drugs, so including Bactrim, are contraindicated in patients with an allergy to thiazide or loop diuretics. All right, urinary tract analgesics. An example, the most common one is pyridium. So it has to be given with an antibiotic. So the pyridium will only treat the pain. It will not treat the infection itself. The pyridium will also turn the urine orange or red, and it can stain clothing, but it's normal for the urine to turn orange or red, and it's contraindicated in patients with liver or renal disease. All right, we have anticholinergics and antispasmodics. Both are used for the treatment of overactive bladder. We've talked about anticholinergics a few times in several other sections, but anticholinergics dry things up. So side effects are going to be dry mouth, constipation, drowsiness, and then urinary retention. It's going to dry things up. It's going to cause urinary retention. Examples are oxybutynin or dicyclamine or bentyl. So it is very important. You do not want to use anticholinergics in a patient with glaucoma, and this is something that will be repeated too. The use of the medication, it may block the flow of intraocular fluid and then result in increased intraocular pressure in a patient with glaucoma. So you do not use them in patients with glaucoma due to that increased risk for intraocular pressure. Now, cholinergics do the opposite. So they're the opposite of anticholinergics. So they cause diarrhea, increased salivation, flushing, or sweating. They're going to increase secretions and perspirations, whereas the anticholinergics are going to kind of dry them up. So cholinergics, they're used to increase bladder tone and function, and they're used to treat non-obstructive urinary retention or neurogenic bladder. They are not given to a patient with urinary stricture or obstruction. So an example is bethanechol, and the antidote for a cholinergic overdose is atropine sulfate. Always know your antidotes. Medications to prevent organ rejection. So they may be used individually or in combination with one another. So you have your immunosuppressants, glucocorticoids, your cytotoxic medications, and then antibodies as well. Immunosuppressants and your steroids are going to be used most frequently, but they can all be used in combination with one another. So cyclosporin, the main thing to know, it of course can be used to prevent rejection of transplants, but two things: it's contraindicated in pregnancy and breastfeeding. So if a patient is on cyclosporin, they must use a physical form of contraception, such as a condom. So they cannot use an oral form. They have to use a physical form of contraception. And then grapefruit juice is contraindicated on this medication because grapefruit juice can increase cyclosporin levels and could lead to toxicity. All right, so sirolimus, also used for the prevention of renal transplant rejection. It is an immunosuppressant, so you're going to have that increased risk for infection, and then it can also raise cholesterol and triglyceride levels as well. Tacrolimus or Prograf is a very common medication that you'll see used. It's more effective than cyclosporin, but more toxic. So it can lead to nephrotoxicity, infection, of course, because it's an immunosuppressant, hyperglycemia, hair growth that is reversible, hyperkalemia, hypertension. All right, prednisone and steroids, they're used for a lot of things, but they can also be used in the prevention of organ rejection. So if a patient is on prednisone, you're going to want to monitor the glucose and the potassium levels because prednisone may result in hyperglycemia or hypokalemia. All right, azathioprine, it's an immunosuppressant. It can cause neutropenia and thrombocytopenia from bone marrow suppression, and then it is contraindicated during pregnancy. Your mycophenolate, it's associated, of course, with an increased risk for infection and malignancies. Also contraindicated during pregnancy. You want to avoid use with magnesium and aluminum antacids and then cholesterol as well because these medications can decrease absorption of the mycophenolate. All right, so I'm not going to attempt to pronounce it, but this medication is used for acute rejection episodes. It's given IV. Along with this medication, which is also used for acute rejection episodes. All right, so we have different hematopoietic growth factors. So you have erythropoietic growth factors that are used for the treatment of anemia or CKD. They will level out and normalize those hematocrit levels within 2 to 3 months. You have leukopoietic growth factors, which stimulate the production of WBCs, and it's used for the treatment of severe neutropenia. Then you have thrombopoietic growth factors, which stimulates the production of platelets. All right, so BPH, medications that are used in the treatment of BPH, you have alpha blockers such as tamsulosin or Flomax, and then you have alpha reductase inhibitors such as finasteride. So those alpha blockers, they relax the bladder neck muscles and muscle fibers, allowing the urine to pass more easily. And then the alpha reductase inhibitors like finasteride, they help to shrink the prostate, but it may take up to 6 months for them to be effective.